Welcome to the Understanding Healthcare podcast with Zach Cantor. I'm your host. Today I have with us Dr. Morris, who's the Chief Medical Officer at Tennr. Dr. Morris is a practicing hospitalist, a former hospital CIO, and the former Chief Medical Officer at Google. Dr. Morris, thanks for coming on the show.
Hey, thanks, Zach. Pleasure.
Well, I thought we could kick things off by maybe you tell us a little bit about the current company you're at, which is Tennr. We'd love to understand a little bit about what they do, who their customers are, and what sort of space Tennr works in.
Yeah, I think for those listening in, you can think about Tennr in the following manner. If you've experienced either yourself or your loved one what it's like to see a provider and they get referred, maybe a referral for an MRI, it might be, you know what, you need this walker. You just injured your leg, or it might be another service. And oftentimes you're kind of told to do these things, but you feel like it's the black hole, right? You don't necessarily know who to go, where to go, what's actually in network. And so what Tenor does is really think about addressing from start to finish the patient flow, the referral of that patient journey, whether it be through the lens of your payer. Are you in network? How much is this going to cost out of pocket? Do I need a prior authorization? Through the provider, how do I ensure that these patients coming into my services are appropriate for my services, or perhaps could be better served in alternative sites of care? And then lastly, I think for the patient itself, having a great patient experience, knowing and having expectations of cost, affordability, and accessibility, I think is absolutely paramount, especially in this climate of healthcare.
So it sounds like, we're going to be talking about referrals across the whole chain of different insurance types. So it's not just HMO, it's PPO, et cetera. You're going to be experiencing across Medicare, commercial, Medicaid. Does it basically work for, Tenor is going to apply across all these different use cases?
Yeah. So, we started out kind of in the DME, which is the durable medical equipment. So think wheelchair or a crutch. We rapidly started growing into infusion services. These are medications administered either in a hospital setting, outside of a hospital setting, or in an ambulatory clinic. And then imaging, and it perpetually grew. So the answer is yes. All payer types, even self-pay, kind of requires a degree of navigation that we feel like we help reduce that friction.
Maybe we could start with that, probably the simplest possible use case there, which is self-pay. Setting aside the, kind of current Tenor experience, what is it like for the experience like for a patient who's being referred from one practice to another as a self-pay patient? Like, you can walk us through the most basic flow when insurance is not involved.
Sure. I mean, a basic flow might be you're handed a piece of paper. It might be a prescription. It might be your after visit summary said, hey, go get X, right? Go get this service. Could be an image, right? Go get an MRI. Now, if it's self pay, you're kind of left to your own devices, right? You have to go shop around and ask, and where is it best, served, and for how much, right? If you're price sensitive, you will certainly look at, well, what can I afford? If you are wanting to, do it with Dr. Famous and the imaging center down the, down the street, it might be for quality. And then the last one is like accessibility. Like, when can I actually get seen? When can I book out that MRI that, my primary care physician deemed relevant? Um,
There's there's a stand-up comedian who does a routine where he says, people always measure doctors by how long the wait time is. And he says like, oh, I've got this amazing doctor, he could see you in 6 months. He says, well, do you have a so-so doctor who can see me this afternoon? Because, I have a gunshot wound.
Absolutely right. So we laugh, and actually, it, in medical school and training, it was always a badge of honor. We call it Dr. Famous, right? Everyone wanted to have the wait list like Dr. Famous, 2 months, right? Badge of honor. It tells you you're doing something right. But as we think about healthcare and access and time and patient experience, I think that lens is changing, because Dr. Famous, while famous, may not be the best person to see you for your issue, or may not be the most affordable or accessible. And I think you have to take in all of those dimensions when you come to kind of patient autonomy and patient rights. At the end of the day, we want transparency and we want, patients and also referring providers to, refer to the right provider at the right time and the right format at the right cost. Now, certainly, there are certain things in life that you want Dr. Famous, right? If I was having my redo coronary artery bypass and I had a bunch of comorbidities, yeah, I want to go to a quaternary referral center that publishes their outcomes X, Y, and Z. Um, but I think what we're talking about is, when you're needlessly waiting 2 months, and then you get there and they go, well, actually, you're better served seeing a rheumatologist. You don't need a joint specialist. I'm glad that you waited 2 months, but your primary issue is inflammation, not surgical. Um, we feel like there is a better opportunity to close that loop.
Super helpful. The, I think everyone's probably had the experience of getting referred from one physician to another. And, just thinking back on my experiences, there's cases where they give you the piece of paper, they say, you should go do this. And then you don't do it. And nobody ever calls you and nobody ever follows up. I think there's a different, level there where they say they're going to refer you over and then you get a call from that the doctor's office, or you might get an email from an imaging center. It says, "Hey, you're supposed to schedule this appointment." What is actually, those are both different types of referrals. Like one is a referral where you're very informal, you're getting a piece of paper. Second is like where there's actually a communication going on between the two providers. Can you talk us through, some of the differences there, and is there like a formal referral process that I know it's not as standardized as a claim or an eligibility check, but is there some mechanism for interoffice referrals?
Yeah, well, we think that mechanism is Tenor, because that referral to a provider. Let's talk your happy path, where actually the onus is not on the patient being the carrier pigeon, but that is either digitally it might be a fax, it might be mail, it might be email. We've seen it all. But either way, those referring providers want to have a universal in basket. They want to be able to get all of these eligible patients to see, hey, am I the best to service this patient? Is this patient's insurance the best to make it affordable, right? What is their out of pocket? All of that. And so the brutal reality is, when we talk about interoperability, it's a great buzzword, but the brutal reality is you've seen one, you've seen one. Patients come in all manners. Still, fax machine and paper is still the lion's share, believe it or not. Because frankly, you have two EHRs, your primary care physician, and then say an imaging center that are not even on the same, um, you know, operating system, let alone, have a direct protocol interface. And so what we first solve is that universal in basket. We will take unstructured analog, i.e., paper, and make it structured, make it so it's computable and automatable for that referring provider. And so now I've got the ability to manage not just those electronic referrals, but patients who, come across, perhaps they're at rural medicine.
So I go to the primary care doctor. The primary care doctor is the one who's a customer of Tennr, and this is the referring provider who's referring me out to some sort of a rheumatologist. Or is it, or it is, you're talking about the provider who's being referred to.
Yeah, it's the receiver, of that referral. So the primary care physician goes, "Zach, we would like to follow up on your symptoms with an MRI." MRI of the cervical spine, and you go, "Great." Where? Right? Because the primary care physician may or may not be affiliated with a system that has, imaging, and so, great, here's a list of imaging. Now, in your unhappy path, you're the conduit, you're calling around, you're submitting your request for MRI, and the onus is on them. We represent the receiver of the referral. So we help kind of create that universal in basket, regardless of the medium of those patients coming in. Second is we can take an email, a fax, even a phone call, turn it into an electronic standard of referral, and then do three more things that are really important. Number one, making sure that if you do have insurance or co-insurance, Medicare, Medicaid, um, that we financially do everything we can to make sure that that service is covered. or is covered as best you can, right? We know that healthcare is expensive and people pay a lot of money for insurance. And so let's make sure that you're seeing someone in network where the service is covered. Um, the second sometimes in as a patient, you may have experienced the prior authorization, right? The insurance wants to make sure that clinically this is a validated MRI, right? Unlike the self-pay where you could probably go down to a standalone imaging center and get an image. I wouldn't recommend it. Um, when it comes to insurance or covered, you want to make sure it's qualified, meaning it's medically within the guidelines of what you would say evidence-based medicine. Um, so we automate that. If it's not, we will reach out to that primary care physician on your behalf. So the patient doesn't have to be in the middle. You have visibility of what's going on, but the onus is not on you. You're not calling up the primary and going, "Hey," and you probably have experienced that telephone tag maybe if you've been given a medication and it's not covered and you feel like you're in the world's worst triangle, yourself, your originating provider, and then the payer. We wanna
Yeah.
dismediate that.
I've experienced it with imaging MRI where the referral goes over and then it goes into a black hole and then 2, 3 weeks later they say, oh, all right, we've got your prior auth done. And in the meantime, have no idea what's going on.
You have no idea, and so, like, that's anxiety provoking, like, having expectation, and even if it's, "Hey, we're gonna schedule this, but it's gonna be about 2 weeks." It's actually profound. It's a great patient experience where you're just setting expectations as opposed to, like you said, it is the black hole abyss. Um, but it's also a great experience for the PCP because they get peace of mind knowing that you're actually gonna follow up on the recommendations that I want, right? They're waiting for that key piece of information, that MRI, the result, such that they can kind of continue to quarterback your care.
It's very interesting. There's this, we talk a lot of internally at Study about the idea of open loop versus closed loop systems, and we try to turn everything we can into a closed loop system. For us, what does that look like? Is that we monitor when customers send claims through us, we monitor the rejections that come back from payers, and we categorize each one by could Study have rejected this earlier or not? Is it something that needed to go out to the payer's utilization management system or not? And so we try and close the loops wherever possible. You know, don't want to name names, but went to I had tweak a back muscle and went to a physical therapy clinic at a major academic medical center, and they do some work. They do a couple things. They give you some exercises, and then from week to week, it's just fascinating that there's no follow. Like there's no app, so they don't know, are you actually doing your exercise? Like the number one thing is going to be compliance there. Think about this with doctor prescribes a medication to you. The doctor doesn't know, are you filling the medication or not? There's a gap there. I think it's exactly the same case that you all are talking about, where you know everybody should be incentivized to follow up on a referral. I need a new walker. The doctor wants me to have a walker. The person who's selling me the walker wants me to have a walker. Everybody wants the walker, but what percentage of those are actually fulfilled is I would imagine tragically low.
You just um, completed our marketing for us. I think we are blessed, and we view this as a blessing because it is a technical need that actually, when done right, positively aligns the desires of all three players: the provider, whether it be the referring or the receiving, the patient, and even the payer. Um, because we know, let's use your physical therapy example. You doing physical therapy for back pain, that referral is really, really important in making sure that you follow up on it because you get a better experience. Your healthcare costs are lower because you don't require the MRI that is going to be needed should you not. We know that the outcomes of physical therapy actually do help and changes the pain receptors and changes your outlook. So it's a lower cost, it's a better experience, and actually both providers, win. That back surgeon, the orthopedic surgeon, doesn't necessarily want to see you because knows that, Zach, you know what, you should try conservative therapy before I take you to the OR. So frankly, they shouldn't be seeing you yet, right? Until all things are exhausted. And so we look at this whole opportunity, great experience for your primary care because now they actually have closed loop feedback for the patient. It's great for you because you're actually getting care that is, proactive and responsive, not and participatory, not kind of left to the onus of you. Um, and then the interesting thing when we think about healthcare access and Dr. Famous's 2 month, um, if I look at Dr. Famous's 2 months, suppose he's the back surgeon in this case, there's probably 40% of those patients that he sees that are actually better served elsewhere, that are better served with physical therapist or a pain medicine provider or sports rehab. And so this isn't about taking away the autonomy of Dr. Famous. It's actually how do I actually improve the alignment of the right patient to Dr. Famous and improve that access. So we think we can actually improve, ironically, Dr. Famous's weight queue by appropriately triaging and navigating patients through a very, very complex system.
Sure. Yeah, it's, the shift left quality problem in from manufacturing, where basically if you're saying, look, the surgeon is spending this much time on consults and this much time on surgeries, that if 50% of them are, the outcome is you don't need surgery, kind of in a perfect world, 80%, 90% of them would be, 100% of them would be you need surgery, assuming that the incentives are correct there, because the people who could have been treated otherwise are getting triaged elsewhere before getting to that queue.
You are spot on. What we solved in durable medical equipment was kind of unique because durable medical equipment, you can achieve a SLA of 2 hours because they are not supply constrained, right? They can always find more supply and they can increase it. Um, the challenge with referrals into a system, whether it be an MRI or a joint specialist, um, you can make that a 2 week to 2 hour technical experience. But if the bottleneck is still, well, Dr. Famous is booking out 2 months, you haven't really changed anything. You've just basically shifted the bottleneck right to the provider. Provider doesn't win. The referring provider doesn't win. They're frustrated, and you are. And so you have to kind of, to the spirit of your original point, solve that closed loop experience and making sure you honor all of the stakeholders in it.
So it's clear to me how, as the um, provider who's receiving the referral, being the primary customer of Tenor, benefits greatly from this and being able to more quickly manage their inbound queue and get all the nice things of turning this kind of deterministic process into something more deterministic. But how does it solve, or is this something kind of still on the roadmap? It seems like in order for you to be solving the Dr. Famous problem, that there either needs to be some sort of marketplace mechanism where the PCP is basically saying, okay, I'm going to look at a menu of here's the queue depth for each one of these physicians, and to be able to choose. Okay, it's like the number one rated rib place in Austin has a 4 hour wait, and you're like, but the probably number seven rib place in Austin is probably really good and probably has a 10-minute wait. You
Hungry are you? Right.
Right, yeah, yeah. I think, there's that, and then I think there's the other way I could imagine it being solved is if you're, receiving the referrals, you may just be able to say, "Look, we don't this is not a fit for us," and you may be able to pass it further down the chain.
Yeah. Um, I think and so we are working on this triage. We've done this in kind of orthopedics and imaging. The classic imaging example is you wait so long for an image, but it actually needs to be what's called reprotocolized. It's the wrong protocol. A radiologist looks at it and goes, hold on a second. For this condition, you ordered X and actually you really need Y. And now they have to rework and do the whole thing. And so how do we short cycle that and shift it? How do we capture these things earlier? If you're, a fan of the goal and process redesign, you have to kind of honor the entire, um,
You're
you
referring
know,
to The Goal, the book by
life.
Eli Goldratt?
Oh, it's the bomb.
Oh, man,
Yeah.
man after my own heart. Wow, this
God.
is like it's
Like
required reading and study.
I completely agree. It's process engineering 101. We can talk about Herbie. Um,
Oh,
but
wow, alright,
Dr.
this is there we go.
Dr. Famous could be the Herbie. And so how do we think about appropriate triage? Um, let's face it, I mean, a lot of these, you know, even single specialty practices or group practices are practicing as teams, right? They have advanced practice providers. They have, physical therapy, other unbelievably highly trained allied health professionals. And how do you actually leverage that full stack? And again, it's a matching game. Is how do I make sure that that patient has, we want an unbelievable experience and the best quality. You want it affordable, right? And in network plan, whatever. Um, and you want availability, right? You want to make sure that this acute fracture or someone with worsening neurologic signs is kind of skipping to the top of the line. You don't want them first in, first out at the 99th position, right? And today, when you book an appointment, it's first in, first out, right? You are getting prioritized now, and the next person who's calling, even if sicker, more appropriate, etc., still goes right after you. And we think that there's a better way to think systemness for health systems. Now, the reality is this is a technology solution plus change management because there is a lot of change, right? This is giving up some of the autonomy of, well, I only want Dr. Famous, and how do we actually reprogram ourselves to think, I want to refer into the system, refer to the practice of orthopedics, and then allow the patient's needs and all of that to kind of help determine, do I need to go to the first rib joint to use your analogy, or is the ninth good enough because I'm starving?
Yeah. Well, that's interesting. There's, some analog there in pharmacy where you can say, okay, is a generic substitution allowed? Is basically you really want the brand name, then you can make sure the brand name gets fulfilled. But in many cases, the generic is going to be fine.
And I think that's, some of the bigger opportunities is transparency. I think patients want and demand transparency so they can make informed decisions, right? They can understand, and we do this a little with medications. I don't know if you've played that game where you pretend that you're going to do self pay and you just see the race condition, and it is eye-opening. I'm not saying it's right or wrong, but it is absolutely profound that, the same medicine somewhere else might be orders of magnitude different, but that's how it is. And the only way to combat that is to give agency. And giving agency to the patients is giving them line of sight, is to stop the black hole phenomenon and make it actionable and insightful.
Could you give some other examples of what are the non-supply constrained? We talked about DME and infusion centers, and what are the other?
I mean, I think, yeah, pharmacy and um, um, devices tend to be non-constrained, right? There could be infinite, right? You can always manufacture more, drop ship, consignment, etc.
Imaging? What is like? Is that
Imaging is very constrained because there are certain modalities like an MRI that just it's physics. It takes time to get the room set up, get the patient set up, and these images tend to take a lot longer than a CT scan or certainly right a chest X-ray, which is less than a is several milliseconds. So there is a time quotient, and obviously a chest X-ray machine or is a lot more affordable than a whole MRI. So MRIs tend to have the longest wait period. And so there are a lot of interesting imaging centers who think about after hour imaging. How do I amortize the cost of this imaging over hours or off time? And you wouldn't be surprised. People will say you're surprised, but you wouldn't be surprised that people are willing to take those appointments, right? Because they've been told that they have a condition or they're concerned or their primary and they want it. And I don't blame them. And so they're willing to do off hours. Well, if you're able to give that visibility to that patient and say A, B, or C, you're going to go to the ninth rib place, to use your analogy again.
Yeah, it's fascinating. I think like let's go back to the goal because many people who hear that reference are not going to be familiar with it. It's kind of an obscure book from the '70s that's famous for being required reading in the early days of Amazon. Can you tell us about the goal and at a high level what the book's about?
What Yeah.
It's a business novel, which is an interesting category. It is a fictional book written with business anecdotes. But yeah, maybe tell us about the book.
It's so, as a physician who was dabbling in leadership and management and IT and kind of and operations, really understanding performance and kind of, if you think about a supply chain or assembly line is kind of the ultimate mecca of kind of a highly tuned system where you have the appropriate amount of resources. You talk about, defect rates and stuff like that. Um, but you're optimizing to, objective, right? Do you want to crank out X number of things, or do you want to crank out X number of things with a degree of quality in healthcare? Obviously, we err on the side of quality, patient safety, um, but access is really, really important because, you know, that 2-month period of waiting for Dr. Famous, there's probably 30% of patients who are seeking their care elsewhere. That's called leakage. Um, maybe it's to a higher quality, lower cost place, or the opposite. Uh, but not recognizing that reality and saying, it's okay to have a 2-month waiting period because we're happy with, 30% of our referrals who are seeking our care to go elsewhere in this day and age, I think is not sustainable, right? We need to understand kind of all aspects of patients' flows. We need to know why patients leave. Why did you choose the sixth restaurant versus not the first one, right? Was it price? Was it availability? Was it quality, patient safety, marketing, whatever? Whatever those attributes are, you have to understand it at each step of that process. And so what we look at is, for us, you have to kind of have visibility and line of sight of when I write that referral all the way to when it's completed. You can't just have 50% of it because, again, if you only solve 50% of it, that last 50% might be bottleneck, meaning it might be broken, and you just shift the bottleneck to somewhere else. And your imaging example, you may have gotten approved and you got the imaging, but we couldn't schedule, you're not scheduled for 3 months. It's not a great experience, especially or the physical therapist, they got your information, but wasn't giving you any feedback, right? Wasn't telling you to do more or less or adjusting. And so, we feel like in order for us to help solve the access issue, it's about intelligent triage and also a lot of communication. And again, the communication and giving agency to the patient and to the referring provider.
Yeah, there's a few interesting pieces in there to unpack. Uh, Many years ago, I heard a quote that said something along the lines of, "Whenever you see a line, you can intuit that the business either doesn't know how to price or doesn't know how to scale." There's some exceptions to that where if so vineyards, for example, like they want to have a very long wait list because there's some brand Ferrari, there's the famous
Hermes bags, right?
yeah.
Which I do not get. That you get chosen to go in the store, you don't get to go into the store, right? Things that defy logic and physics. But
There's a famous story of from the early days of Enzo Ferrari where it's very early days. He's running this factory behind his house or whatever. I forget exactly the details. And somebody comes through for a tour, and this wealthy person, and they come to the end of it and say, okay, I would like to buy a Ferrari. And he says, Enzo Ferrari says, okay, it's going to be 12 months. And and after the guy leaves, his worker comes up. He's like, Enzo, we have 7 Ferraris waiting to go. And he says, a Ferrari should be desired. And so that's like the luxury thing. I don't think anyone's saying MRI should be desired. My MRI machine should be desired. I think that the pricing, issue there is really that there's some sort of like, there's a market distortion in that there's what if everybody were self-pay, you would have Uber-like surge pricing, and there would be different prices for different times of day. And a Saturday appointment would be much more expensive, and Monday at noon when a lot of people are working, it would be whatever. So that you would see this happening, but it's an interesting problem. And to go back to the goal talks about bottleneck optimization. And it goes through this fascinating story of a guy who takes over a failing factory basically, and he's thrown into two levels above management where he's used to doing, and he has to figure out what is wrong with production. And the kind of learning from the book, one of the pieces of learning is that you look at a giant factory floor. There's tons and tons of different machines running. Um, you know, the statistical likelihood is that there's only one bottleneck, meaning like in the whole, there's 1,000 machines running. There's one machine that is constraining the output of the whole factory. Um, and so when
which
you
is
look at
which is
this, it's like,
which is intuitively just amazing, and it's spot on, I mean, mathematically, but it is fascinating, and then the next question is, do you know what that bottleneck is? And that is, I think, like, you know, crawl, walk, run is, do you have visibility? It would be one thing if Enzo had a 12-month waiting period, but he doesn't even know the number of people who would actually be happy to wait on the 12-month waiting period, who are not even getting into the queue.
sure. I mean, and that's what we see with AI adopt. People are talking about, okay, here's look at the revenue ramp of Anthropic, and they're saying, and that's with API usage restrictions. We don't even know what the true demand for these things are. I think we don't really know what the true demand for healthcare is. Like because we control in so many ways, because otherwise it consumes 18% of GDP. It would consume 80% of GDP if it could.
Yes, that is true, and I think there are I am appropriate use. So this is not just, hey, I want, I get, but I think there has to be, and again, appropriate throttling and management, because otherwise we'd, like you said, we would have entropy. And that's why, we ground all of our models in the qualification guidelines. If it's, something like, you know, um, oncology, we're never the source of truth. We're not the deterministic, but industry standards or knowledge source like NCCN or others. And so, making sure, um, again, the AI doesn't do this, is accountable to the human, and the human is accountable to what we'd say is peer review or evidence.
Well, I think that it's a good forcing function. If the system breaks, if if the system would break if 100% of DME orders were filled, and because some Tennr and other mechanisms solve the whole problem of the closed loop system, and all of these get fulfilled, then we have something else we have to fix. It's not good to say, well, we need a broken referral system in order to have 30% of these things get fulfilled. It's you're just denying reality.
Yes, and again, are all 30 of those percent need something? Maybe not, but a certain percent does. And so what scares me is those patients who are not getting appropriate care, who are not getting, workup, or being disenfranchised or underheard, underserved. Because that is just as bad as our, overspend is the underspend of those who are truly in need, and understanding that root cause. So, if we can make the invisible visible, we're not going to solve everything, but I think that's the first step in kind of understanding that awareness of where are my bottlenecks. And then how do we work kind of during the, you mentioned, we talked a little bit about the change management. It's one thing with the technology can make things visible, but it is always a technology issue, or do I have a process issue? And so that's where we spend a lot of time working with our customers on process redesign, not a technical side, but a lot of the change management. We think there's plenty of opportunity on that as well.
Very helpful to understand. And can you walk us through what an actual implementation looks like in terms of people? I'm sure come to you and probably are doing things with emails and spreadsheets and fax machines on day
Everything.
one.
Yes.
How does the on ramp process work?
Short of an abacus, we've seen it all. I think early on, we came with a lot of our tooling and said, well, let's shadow you, and let's take what you have and put it on rails, meaning, well, let's mechanize that process. I think over the past 5+ years, we now have kind of a well-informed opinion on kind of not only the normal processes to go from, A to B, um, but, you know, how do you think about automation? Where doesn't the human need to be, and where should the human be, and how do you kind of balance those two? Because the worst is if you throw technology just at a broken process, you just get broken faster and more expensive. And so our engagement leads with our customer satisfaction team. We go in, spend time,
Everybody reads the goal first, I'm sure, in the first week.
everyone reads the goal. You don't spend it in the C-suite at a boardroom table. You spend it in the basement, the sub basement, where work is performed. Right? You want to do development where work is performed, and we are very intentional about that. We really want to understand the nitty gritty. Right? Just to the goals analogy, you have to understand all of the orchestration of those individual assembly parts and what their work in process is and what their throughput is and error rate, all of that. So we map that all out. We will do their integrations, get that universal in basket. We will then build out custom. We have our own proprietary tuned models for healthcare, but again, you've seen one healthcare system, you've seen one geolocation, right? Different payer guidelines, different, small blue plans. So it's really, really important for us to, again, reflect the uniqueness of a health system, right? Those little idiosyncrasies that reside in Sally's brain, how do we actually bring them to light and automate that? Like, that's actually a lot of the work, as much as the technical integration, making it so it's invisible, right? Invisible into their workflow, in their EHR. Because at the end of the day, we don't want them to think Tennr. They should be just thinking about that patient in front of them and fulfilling their own goal.
I know you've came from a health system background. I'm curious, if you look at a health system, um, large academic medical center, or maybe someone like Kaiser, presumably within Epic, they have functionality for referrals when you're referring within the health system. Yeah, and is that, is there like a fairly happy path there for, you go to Stanford and Stanford refers you to the Stanford Imaging Center?
Um, yes and no. Um, I think the happy path of I pass electronic referral, right? So I don't need document AI and OCR and all of the technical jargon, right? Because it's already verified technical data. It's high quality data, and so we don't have to solve for that. But even something of an infernal referral still has to go through, what's my eligibility? Is my benefits covered? What is my out of pocket? And do I have to sign a prior authorization? That's a human. So there are still inordinate opportunities for health systems to take out unwanted cost, but also time that interjects itself into that referral process. And then you get a question though is, okay, well, then Epic files and you make the appointment in what's called cadence. Um, but that's still first in, first out. How do we actually bring intelligence to what was the clinical indication of that referral? What is the capacity of the referring provider? Um, what are all of the criteria around that patient, whether it be payer, their primary or secondary insurance or self-pay? Um, and given all of the capabilities within my system, answer the question, who is best to serve this patient? It might be, would you like to be seen, tomorrow with a telehealth visit? Because your lower back pain is most likely going to benefit, following the evidence, is aggressive physical therapy. We got to crawl, walk, run before we jump off into, oh, you need imaging of the spine, or you actually need a spine surgeon to comment. And so we look at clear opportunities. If you talk to any US health system, and access is usually one of their top 3 or 4 things, right? They want to be able to serve the needs of their community. But thus far, their scaling function has only been one dimension, which is how do I make my providers more efficient, right? Give them Dr. AI to chart a note quicker. And, maybe we can squeeze out 2 extra patients in a day, right? That's a capacity play. Or maybe we acquire a new practice. Um, we're looking at it as what's the efficiency, how well are we at matching the patient's needs, all of the criteria to the right provider? And we think that there is at least 30 to 40% opportunity to um, achieve the same clinical and high quality goals, but decant or disimpact some of the clogged service lines, if you will. Not everyone needs to go to Dr. Famous.
Super interesting. Well, look, this is extremely helpful in getting the audience up to speed on referrals and understanding the ecosystem, what things are like today, and how things could be. Uh, we'll close with our traditional question, which is, if there's one thing that you could change, a single thing about revenue cycle management that doesn't require a fundamental reworking of the system, what would it be, and why?
I think it's not a change, but I think the opportunity is that left shift is um, informing the ordering provider or the referring provider with information, right? And for that patient is how much is this going to cost them? Is it covered? And where are they, where can they best be served? Because I think when you talk about informed decision making, your provider wrote you a prescription for that MRI. Um, but is that really the end of that informed decision making? What happens if, well, you could do this, this, or this. If you really, really want an open MRI, it's going to cost you X, Y, and Z. Here are the 3 practices, but they're not going to be able to see you until 3 weeks from now. Clinically, there's no reason to worry about this. You'll be okay. That to me is informed decision making. And so it's not necessarily a wish, but it's the vision of giving agency at the point of care with all aspects of information to allow what I think is the most sacred aspect, which is the conversation, the human element between provider and patient. And more information that is timely and relatable is a win.
Yeah, what I'm picturing is the Bloomberg terminal where, the people don't realize one of the big features of the Bloomberg terminal was and is the messaging between professionals. So it's like, you're on Bloomberg Messenger, which is, you're messaging with your, counterpart of at the, mortgage trading desk at Goldman. And it seems to me like if they could
It
do
was
that
so-
with
it
options,
was
contract, commodities
yeah,
and everything.
it was social networking before there was Facebook, and I would agree there was a lot of social engineering and that kind of collaboration. But I think it to me actually reflects the systemness. It's a team based in alignment as opposed to it's just Dr. Famous.
Yeah. And you can get Dr. Famous on the messenger and say, hey, I got a patient who needs this, this, and this. And the Dr. Famous can say no, but here's 6 other profiles that, I think might be good.
Win-win.
Yeah. Well, thanks for coming on the show. Very excited about what you all are doing, and would love to continue the conversation.
Thank you, Zach. Really appreciate the time.
Take care.